Okie dokie. We are going to go ahead and get started. Thank you, everybody, for joining us today, taking the time out of your busy days to be with us. I see Christy's in her car driving. So thanks, Christy, for joining. And also, thank you guys for already starting to rename yourselves. That's helpful. I've already taken most of the attendance. So welcome. My name is Maggie. I am one of the program coordinators of REACH. And today we're going to be talking about management of gastrointestinal symptoms. It's the 5th session today, so welcome to anyone who is a newcomer. And if you are returning, then welcome back. We're happy to have you. So just going to get started with some housekeeping announcements like always. For starters, we are going to be collecting registration, participation, chat comments, and this data is going to be used for reports, maps, communication, surveys, quality assurance, evaluation, and to inform new initiatives. Your data will be kept confidential and just be used for educational purposes. The recording of this session will be for educational purposes, and we will later make it available to you all on the website. So by participating in this session, you are consenting to being recorded. So thank you for consenting to that. And if you have any questions, feel free to email me. One note, we are going to be discontinuing the REACH email account. We've just had some issues with getting that up and running, and we're going to just switch over to my email account. So maggie.palopoli@lcmchealth.org would be the best email if you have any questions or concerns. And I'll put that up in the chat as well. But going forward, instead of emailing that REACH account, just go ahead and email me directly. So we are accredited through LMH PCO to provide continuing education units to nurses that are seeking it. So if you would like to gain CEU credits after the session is over today, you will be receiving an email from LMH PCO to complete a post-session survey. So all attendees of the session today are going to get that email. You only have to complete it if you are seeking CEUs. It's going to be mandatory if you are wanting the CEU credits. So fill that out, and our goal is to get that to you within a week of the session ending. So after a week, if you haven't received that, just shoot me an email and we'll make sure that we get that to you. So I think we're all familiar with the Zoom etiquette now, but just if you're not speaking, we ask you to stay on mute. If you do, we would love to hear you talk. So please come off mute before you speak and want to share something. If you have comments or questions, you're welcome to also use the chat, or you can use the raise your hand function, whatever you'd like, but just keep yourself on mute while we're presenting, and then come off when you have questions. If you have the bandwidth, we'd love to see you. So if you could put your cameras on, we do understand, of course, if not. I think most of you all have done this, but if you haven't yet, if you could go ahead and rename yourselves. There's 3 dots at the top right corner of your Zoom screen. If you could go ahead and put your first name, last name, and then organization that you're a part of, that will help me for taking attendance and getting the post-session survey to you all. Again, raise your hand or use the chat, or just come off of Zoom if you have anything to say. This is a safe space for everyone, so we want to make sure that you feel that you can share whatever you'd like to share. We do ask that you use de-identified information when you are sharing, just to protect the privacy of all participants and individuals. And everything discussed today will be kept confidential. Okie dokie, I'm going to hand it off to Dr. Mo now for our agenda.
Hey y'all, I'm Lexi Morvant. I am the Chief of Pediatric Palliative Care at Children's Hospital New Orleans, and I work alongside all these fabulous people. Um, I am really excited that everyone is joining today. I know y'all are all very busy. And we're going to start with introductions. And so if each one of you feels comfortable and it's safe for you to do so, could you give us your name, role, and organization? Dr. Autry, do you want to go first?
Yeah, we'll go ahead and do the reach team first. Hey everyone, I was here for the first session in January and then I went out on maternity leave. So I'm happy to be back, and I was so excited to hear about some of the sessions that y'all have had, and how many nurses and different professions all across the state have been joining in. So we really appreciate y'all. I am one of the pediatric palliative care physicians here at Children's Hospital in New Orleans, and I've worked with the team to kind of get this project going. And we are very thankful to St. Jude, who has also done the project within the state of Tennessee. So that's about it. I'm from New Orleans, and I'm happy to be practicing palliative care in my home area. And also update, I had a baby boy, Charlie, and he's doing great. He's such a happy baby boy. I'll show you one quick picture. Oh, wait. Oh, shit. I can't. Maybe by the end of the session, I'll get that together. But yeah, happy to be here. Maggie, do you want to go ahead next? Or I guess go ahead next, Mag.
Sure. Hey y'all, I'm Maggie. I am one of the program coordinators for REACH. I am just a volunteer researcher and part of the palliative care, I guess an extension of the palliative care team, just in volunteering. But I'm starting medical school in the fall, and just have an interest in palliative care. So I am really grateful and excited to be here. And yeah, I won't be able to be joining in person for most of our future meetings, but we have another program coordinator, Masood, who's going to be helping out with the session. So I will hand it off to you, Masood.
Thanks, Maggie. Hey, everyone. My name is Masood. I help support the palliative care team here at Children's, and I'm one of the program coordinators alongside Maggie. Super excited to have everyone back, and for the new people that are on as well, very excited for everybody and for today's session.
I think it's me. Hey everyone, I'm Kenzie Daniels. I am up here in North Carolina at University of North Carolina in Chapel Hill, practicing palliative care, both on the adult side and some on the pediatric side, and also have some hospice time in there as well. I did my training, so my hospice and palliative medicine training down in New Orleans, and that's how I know this wonderful team and was trained under Dr. Autry and Dr. Morvant. And excited to be here today.
And then Stevia.
Stevia Davis is our nurse practitioner for our palliative care team at Children's Hospital New Orleans. She is doing strong work right now, I'm sure, while on mute.
And just special shout out to Stevia for holding down the fort on our project while I was out on maternity leave.
All right, Cheryl, do you want to go next?
Here I am. So my name is Cheryl Churn. I'm the LCMC maternal fetal medicine navigator. So I work with the high-risk mother-baby dyads at all of our 3 delivering facilities within LCMC.
It looks like Christy's walking. Christy, are you safe to talk?
Yes, I am. I'm Christy Heitmeyer, RN. I work with Heart of Hospice. I am the pediatric field nurse, pediatric PCM, and consultant, and I am on the board for the REACH initiative. And I'm happy to be able to see y'all at the LMHPCO conference.
Thank you, Christy. Lisa Goings.
Hi, my name is Lisa Goins, and I am the hospice director at North Oaks Hospice in Hammond.
All right, Judy.
Hi, I'm Judy Zarang. I'm part of Children's Hospital as a nurse navigator and one of our palliative care champions. I'm happy to be here and good to see you, Kenzie.
Cindy.
Hi, my name is Cindy Fowler. I'm the director for St. Tammany Parish Hospice and started my career working at Children's in the PI for years and years. So I'm trying to see if we can increase our pediatric population over here.
Wonderful. Mandy Benoit.
Hi, I'm Mandy Benoit. I work with Allegiance Hospice and Palliative Care. And we are building our pediatric program. We're in the process of doing that right now.
Yay, I love hearing that. Courtney Kelly.
Hey, I'm Courtney Kelly. I am the Hospice Clinical Operations Manager at LHC Group, and we are also in the process of rebuilding our pediatric program.
Whoop, whoop. Laura Mooney.
Hi, my name is Laura Mooney. I am our Regional Director of Quality Outcomes for Compassus. I help oversee Louisiana, Mississippi, and Tennessee. I am out of the New Orleans area. We currently don't service many pediatrics, so I wanted to attend just some curiosity and kind of learn because some of our Mississippi and Tennessee programs do.
Wonderful. And I think the last one is Tammy. And if I missed anyone, holler after Tammy, but I don't think I did.
Hey, I'm Tammy Ide. I'm the manager of supportive care services at the Lake. I'm actually not on video. Oh, I still have my Spirit Week logo stuff behind me because we did Camp Spirit for Spirit Week for Hospital Week. I am over the palliative care department for Our Lady of the Lake, which encompasses the Baton Rouge market. So we currently have some palliative care at our children's hospital, but we are seriously looking into making that a more robust program. So I like to attend these meetings just so I can gather more information in regards to that. And we also, in July, will start a palliative care fellowship program. So exciting.
I did hear that. I think I'll be one of the PEDS teachers for that. I'm really excited for y'all. That's awesome. All right. Well, I think that's everyone. So overall today we're going to talk about GI symptoms, and it really is my pleasure to welcome Dr. Daniels here again. She is a fabulous, amazing physician. And I'll let her take it from here to go over the objectives. But we're going to do objectives. She'll get into the didactic piece, and then we're all going to review a case together where you could ask questions. You could throw out questions that are either related to GI symptoms or not. And we're here to make sure that you're learning. So with all that being said, take it away, Dr. Daniels.
Thanks, Dr. Morvant. All right, so we're just going to jump right into it. So objectives today, Lexi just went over a lot of those, but really we want to get down to discussing common GI symptoms that many of y'all are seeing out in the field and that affect people living with serious illnesses. So those are including nausea, vomiting, feeding intolerance, constipation, anorexia, cachexia. Some symptoms that we're really not going to discuss in detail today, but you're more than welcome to ask questions at the end. Diarrhea, reflux, dysmotility. And we'll review not only just kind of the etiology of the symptoms, but also kind of the more practical piece about how do we treat each symptoms, or what is our treatment approach for each symptom, meaning evaluating, trying to identify the cause, what are the goals of care of that patient and their family, and talking through non-pharmacological and pharmacological therapies. Next slide. All right, so let's just start with nausea and vomiting. So really with any of these symptoms and illnesses, we want to do a comprehensive evaluation to really identify what could be causing the nausea and vomiting. I think so often we have kind of our toolbox of what we treat with for nausea and vomiting. And I think to go back further and to treat it and to think through it about what medication is going to be more helpful, we first have to decide, well, where is the vomiting coming from, or where could it potentially be coming from? Because that will inform, you know, the receptors and the medications that we use on those receptors. And so really trying to do a careful history, including when did it start, kind of how is it happening? Is there something that's causing it? Is it associated with or exacerbated by something? What is the quality of it? Are they having, you know, is it, you know, bile? Is it green? Is it yellow? Is it food coming up? What's the severity? And what other symptoms are going along with it? Of course, reviewing the medication list is important, and physical exam, certainly focusing really on the abdomen and the neurological systems. But physical exam can be tricky, especially when people are nearing the end of their life. And so some things that have been helpful are just thinking about a scale. So one of the validated scales in neurologically intact children, really as young as 4-year-old, is this BARF scale. So kind of looking and assessing the patient's facial expressions, they're grimacing, are they diaphoretic, are they actively vomiting in front of you? And so evaluation, as you can imagine, is more challenging in really non-neurologically intact children or children with developmental delay or disability. And a lot of times we're relying on the parents, right? They know them best. And so talking to them about what has been going on. And remembering that, and we'll go into next slide, the common causes, but many things, especially in that medication review, the list that many medications can cause nausea and vomiting. So going into just some of common causes, we'll review some with pediatric patients, common causes of nausea and vomiting. This applies to adult patients as well. And really that thorough evaluation of history taking and physical exam will really kind of help you determine the likely cause so you can target your treatment appropriately. If we look at this, it's pretty much divided here in GI causes and nervous system causes. Remembering that our nausea receptors, our chemoreceptors, are in our brain, and receptors go into our gut that can also cause vomiting or nausea feelings. And so some of the big ones when I think of that we'll highlight here for patients pediatric patients on hospice. So obstruction or ileus. So I think of this often, especially obstruction in people who are living with advanced cancers, depending on where their cancer is and what their metastatic disease looks like, certainly can be a cause of obstruction. Ileus kind of goes hand in hand with constipation, which is often a very common cause, and we'll go much more into detail about constipation a little bit later. Meningeal disease, if we look over here in the nervous system area, so that can include infection, like does our patient have meningitis, or is it a tumor involvement, right? Is there something going on in the brain that is causing, whether it's increased pressure or irritation or leptomeningeal irritation? So those things can cause nausea and vomiting as well. Medications, I think, is the first place I always go and look really hard at their medication list, because so many things can cause nausea, and those are things that many of our patients are taking. So opioids certainly can cause nausea, antibiotics, NSAIDs, chemotherapy. So taking a good look at the medication list. Other things where it says metabolic abnormalities, that's when we think of, if a patient is uremic. So maybe it's a patient living with end-stage renal disease or worsening advanced kidney disease. That could be uremic. Hyperglycemia, hypercalcemia. So certainly in patients with cancer, calcium can go high, and other reasons. And liver failure is a big one. one that I think we often forget about, or I certainly do when I'm evaluating patients, is visceral hyperalgesia. And I know my pediatric palliative care colleagues think about this and stress this a lot to me when I was going through training. But this is for people, and this can be a big cause of nausea and vomiting and feeding intolerance for our non-neurologically intact patient populations. So patients who are living with neurologic impairment. And it's really, so what visceral hyperalgesia is this increased sensitivity to pain in the internal organs of the body. So things like the intestines, the stomach, the pancreas. So they have, increased pain compared to kids who are neurologically intact. And this can manifest as things like nausea, vomiting, feeding intolerance, pain, agitation, irritability, and really, again, relying on parents or caregivers, whoever's caring for them, to help guide you in what's changing in their behaviors. Go to the next slide. So we always want to think when we're approaching treatment options, kind of before that, well, what are our goals, right? What are our goals of care? So where is this patient in their illness trajectory? Are we days away from dying? Are we weeks, months, years? Where are we? And that can help guide recommendations. And what are the patient and the family's goals currently? That could be, maybe they want to stay at home. Maybe they want to come to the hospital. And this is all in the context of remembering that patients can receive disease-directed therapy concurrently with hospice and comfort care. Pediatric patients can. And then once we figure out the goals, really trying to align our treatment plan with the goals. So go to the next slide. We'll look at the non-pharmacological treatments first. And this is kind of where I always encourage everyone to start with really any symptom. Is there something we can do before medications, right? Trying to limit, because so many of our patients get so many medications added. So is there any way that we maybe don't have to add, or we can try other things first, or maybe we even deprescribe some medicines? So some of the things to think about for non-pharmacological management are, can we remove any medications that are causing nausea? How about decreasing their feeds or changing the feeds if they're having feeding intolerance or nausea? Certainly minimizing strong smells, maximizing their environment, making sure it's comfortable, they have their favorite foods. Also things like acupuncture or acupressure, aromatherapy, hypnosis, psychosocial support, certainly for both patients and their families. And we'll talk about this a bit later, about feeding intolerance in the context of progression to end of life, and recognizing really that discussing feeds, and I'm sure many of you have encountered this, discussing with patients and typically their families about decreasing feeds or stopping feeds will be very distressing to many families, most families, because feeding is a cornerstone of parenting, right? And so helping, guide and support families in this decision-making is really paramount. And we'll have some resources at the end that you guys can refer back to about how do we have these conversations. And one of those resources is the Courageous Parents Network. Has a whole section about how do we talk to people, how do we manage nutrition at the end of life. And there's also a resource just about non-pharmacological resources for nausea and vomiting that CHOP in Philadelphia has a website. And we were gonna, I think, paste the links in there now, and they'll also be included at the end of our resource section. So next slide shows when we think about medications, right? So we've done the history. We're trying to get a sense of, is this more, do we think it's coming from GI? Is it more kind of reasons that we think they're having nausea and vomiting. Maybe it's a combination. So what should we be reaching for? And these will briefly review the medications, the potential medicines that you can use to address nausea and vomiting. And really, this is, y'all have heard of many of these, and this is just to add more to your toolbox. And you can refer back to this, and we'll also give you helpful resources. I think one of our favorite ones that all of us use is the Dana-Farber Blue Book. And Dana-Farber has a great website. They have 3 different books to help with symptom management. And those are also resources that we will have at the end and likely paste into the comment section. That's a good way to refer back to common medications used in nausea and vomiting, and also pediatric specific dosing. So to briefly review this, I think we'll look here. I like to look at the class of medication first. So we think again about receptors. So serotonin receptor antagonists, Zofran or ondansetron. This is kind of our go-to, right? I think most people are grabbing ondansetron first, and maybe sometimes it shouldn't be first line when we think about what could potentially be causing the nausea and vomiting. But it's certainly first line when it comes to chemotherapy-induced nausea and vomiting. Can also be helpful in opioid-induced nausea and vomiting and gastroenteritis. We have Benadryl, diphenhydramine, and scopolamine patches, and meclizine, which are all anticholinergic medications. Remembering that we do like these medicines, and I will caution you too that so the anticholinergics going to cross the blood-brain barrier and can potentially cause increased sedation, increased confusion. You probably all certainly see this in adult patients, and can see this definitely in kids as well. And we like some of these, like meclizine, if we think there's a reason that it's like actually coming from like the inner ear or something vestibular causing more vertigo and dizziness, that's a good one to reach for. And that's where your history will come in handy. Another one we love, and is getting way more attention now because of research coming out, is olanzapine or Zyprexa, an atypical antipsychotic. And this is really helpful when we think about chemotherapy-induced nausea, vomiting. It's usually like the second one, maybe third one I reach for, and can be helpful in appetite and weight gain as well. Other ones to think about on the next slide are we'll go one more slide up to Decadron. Yeah, that slide, perfect. So Decadron steroids, of course, can help with many different things, obstruction, high intracranial pressure, if there's mets in the brain or brain masses itself. Chemotherapy-induced nausea can help with appetite, weight gain, and energy. But again, recognizing where are we in this illness trajectory, because we don't want to put someone on just indefinite steroids if they have, potentially months or years to learn or to live, right? It's a conversation with the family. It's used, like we can put people on steroids for indefinitely. And I think about that when people are typically in the last days to weeks of their life. Other ones we use commonly in pediatrics much more, I feel like, in pediatrics than in the adult world, is lorazepam. I mean, we use that very often in hospice, lorazepam as a nausea medication, as well as haloperidol. Metoclopramide and promethazine. And those are all dopamine antagonists. So when I think about things that are going on in someone's gut, so if I think it's more GI related, maybe they have an obstruction that's causing them nausea, vomiting, those are ones that I typically grab for first. There's octreotide. We won't go through all of these in great detail. On the next slide too, these are medications that are not commonly used for nausea and vomiting, though they are ones to just remember. So low dose naloxone if we're having really intense opioid induced nausea, vomiting, or opioid-induced constipation. Glycopyrrolate and atropine drops can be helpful for increased secretions. Again, remembering these are anticholinergics and cross the blood-brain barrier. Gabapentin and our PPIs. So that's nausea and vomiting. I've not been monitoring the chat. I don't know if there's questions. But if not, we will move on to the
No
constipation. Okay, perfect. We'll move on to the constipation section. So again, we are always wanting to do an evaluation to really try to identify what is the cause of constipation. So including onset, timing, how severe is it, what other symptoms are associated. Nausea and vomiting and constipation often go hand in hand. Reviewing the medication list, because there's certainly medications that many of our patients are on that cause constipation. And doing a physical exam, again, focusing on the abdomen. Oftentimes in pediatrics, you can really feel kind of the stool balls and stool in their abdomen. Potentially doing an external rectal exam, and again, doing a neurological exam. We don't recommend, typically internal rectal exams, right? Just one being making sure that we're practicing trauma-informed care with our patients. And also we want to use extreme caution in patients who are living with cancer, who may be neutropenic or may be thrombocytopenic, and we can increase the risk of infection or bleeding by doing anything rectally, including like suppositories. So what are some common causes of constipation? So again, they're kind of broken down into sections: GI, nervous system, metabolic, and medications. And your history and physical exam are going to likely help you determine the most likely cause to target your treatment. So GI tract, so decreased fluid intake, decreased fiber intake. And this is often happening with our patients on hospice, just kind of reduced activity in general. Maybe there's obstruction like we had talked about. Nervous system neuropathy, is there spinal cord compression? Metabolic are pretty similar to the ones that we talked about before for nausea and vomiting that can cause constipation. And then medications, again, a very big side effect of medications we often use. And so those can be opioids, anticholinergics, antiemetics, and the ones that we think of often are ondansetron or Zofran is a very constipating medicine. So as we reach for nausea and vomiting, and maybe someone's having nausea and vomiting from their constipation, recognizing that if you're reaching for Zofran as your first line, you're going to worsen that constipation. And so we'll need to be either reach for something else or have a really, aggressive bowel regimen. And there's other medications too listed on this list that can cause constipation. So again, before we reach for a treatment, what are our goals? So again, eliciting goals from patients and their families, determine kind of how, where are we going to treat constipation? How are we going to do it? And so then we can go into our non-pharmacological management next, after eliciting the goals. Do next slide. And these are several things that may or may not be feasible in your patient. One is just could potentially be feasible as changing or removing constipating meds. So again, like the Zofran we talked about, can we switch it out with something else or make it at least not first line for their nausea? We can increase fluid intake, increase fiber intake, potentially increase activity level. And again, this may not be possible depending on where your patient is in their illness trajectory. Massaging, certainly doing some light massages on their bellies and kind of moving their legs around, some biofeedback and manual disimpaction, which is not commonly done in pediatrics, again, with the reasons we talked about before, but certainly a possibility. And then when we think about treatment, right? So again, breaking it down to class of medication, I like to call it to my patients the mush and push. So osmotic laxatives is the mush, right? We have to make our stool softer in order for it to come out easier. The stimulant laxatives stimulate our bowels to push things along. So I typically have most of my patients on one of each, a mush and a push drug, an osmotic and a stimulant laxative. And you'll notice before we go into this that we did not include Docusate or Colace on this list. And that's because multiple studies have really shown that Docusate is no better than placebo in treating constipation. So it's not one that we reach for in patients who are struggling with constipation. And many of these are used for, the goal would be prophylaxis, right? That we're not getting to the constipation point, but then we can use these also for treatment. And dosing is going to increase with the indication of whether we're doing it prophylactically or treating constipation, and maxing out the dose if needed for evacuation. Again, the Dana-Farber Blue Book is a valuable resource for looking at max dosing and these meds that can help with constipation. Many of the ones y'all are already used to, so polyethylene glycol or Miralax, lactulose, mag citrate. Mag citrate's really only reserved for evacuation when we really need someone to have a bowel movement because it's been too many days without one. Senna and bisacodyl are stimulant laxatives, and those are all commonly used in pediatric patients as well as adult patients. Next slide shows things that are, when we talked about the mush and push from above, those are above medications. We can go from below with suppositories and enema. Often, again, we're not utilizing these a lot, especially when it comes to patients living with cancer, pediatric patients that have cancer, because of the risk of infection with neutropenia and the risk of bleeding with thrombocytopenia. But you can always discuss this with the pediatric oncology team if you think it's appropriate, depending on the goals of care of the family. So there's all sorts of suppositories that aren't even listed here, all of them, but one of the ones we like is a glycerin suppository to help stimulate the bowels. Fleet enema. So this is to be avoided in patients with kidney disease, who are end-stage renal disease or chronic kidney disease because of the electrolyte burden. So that's something to remember, but you can always use other enemas, like mineral oil enemas or soap suds enemas. Another medication that we can use that's not listed on here for opioid-induced constipation is methyl naltrexone or Relistor, which is a subcutaneous medication. They also make kind of similar medications. They're all called Pomoras. But things that you maybe have seen like on the television of like Simproic or Movantic, those are medications that are pills. That all of the medications, unfortunately, are still under, what's it called, patent, not patent. They're all brand names still. So basically they're very expensive medications. So really hard to get outpatient, or I would be interested to hear if anyone's hospice agencies are covering those medications. All right, move on to the next section. Everyone hanging in there? Not too much longer till we get to the discussion or the case. So anorexia and cachexia is the next kind of group we're going to talk about. So anorexia is the loss of appetite or just the desire to eat. Cachexia is more complex than that. So cachexia is really kind of a complicated and complex metabolic disorder that leads to muscle, protein, and lipid loss that is not reversed by nutrition intake alone. We mostly see these in patients with advanced cancer or HIV/AIDS when we think about cachexia, or in patients who are at the very kind of end stages of cardiac or in pulmonary conditions. Anorexia and cachexia, they may present alone. They could present together. And these lead to malnutrition and continued weight loss. So looking again at the causes, doing exams, doing a careful history, medication list, make sure nothing's causing them to have a decreased appetite or being nauseous that's causing them to have a decreased appetite. There are some common symptoms listed there about reasons people may be not eating as much, and that could be reflux, pain, maybe they have mucositis, nausea, vomiting, constipation, which we've talked about, obstruction, maybe they have depression or anxiety. There's a lot of reasons that people have decreased appetite. Cancer in general, with just the kind of inflammatory cytokines that are released, can cause people to have a really decreased appetite or get full very quickly. And maybe they don't have any of these actual things going on, but they just have cancer in general that's causing them to have a decreased appetite. Or maybe they're on chemotherapy, which is causing them to have a decreased appetite. So as always, discussing the goals of care around how we treat anorexia and cachexia. Again, as a child moves towards the end of their life, there's likely discussions and decisions that are being made about managing nutrition. And it's really difficult, as we discussed, because families really, cornerstone, like we talked about, feeding is the cornerstone of parenting. And so this is a really difficult part, I'm sure that many of you have encountered. And again, we'll share the resource that they probably already shared, the Courageous Parents Network, to help discuss managing this difficult conversation. So when we think about non-pharmacological therapy management for anorexia and cachexia, so we want to offer our favorite foods, right? Favorite foods in smaller more frequent meals as able. And if those could, potentially be, high protein or high calorie, that would be great. But I think make sure we're offering our favorite foods and in smaller quantities. Eliminate foods that have unpleasant odors, and maybe they don't have unpleasant odors to you or to the family, but they certainly could have unpleasant odors to the child. And if able to, improving someone's functional status, just their ability to move around. Because like we said, just decreased movement can also lead to constipation as well as anorexia, cachexia. Other things that we talked about similar to nausea and vomiting are hypnosis, acupuncture, aromatherapy, just relaxation and guided imagery, massage, music therapy, and again, thinking about that psychosocial support when it comes to thinking about decreasing or stopping enteral nutrition as pediatric patients or as anyone approaches the end of their life. When we go to pharmacological management, so disclaimer here is that we don't really have good medications to help stimulate people's appetites. There's even more evidence coming out recently, even in the last year, that shows we don't really have anything great to stimulate appetites. So we really try to treat kind of the reversible causes. Is there pain? Is there constipation? Is there nausea and vomiting going on? Can we give them like insured drinks or supplemental nutrition? Are they already getting tube feeds or something that is supplying them with more nutrition? We can consider those appetite stimulants listed there, cyproheptadine, olanzapine, dronabinol, dexamethasone, Megace, knowing that, what we're looking for when we increase someone's weight is to increase muscle mass. And a lot of these medications, they don't do that. They don't increase muscle mass. They increase kind of fat distribution. And so that's not necessary if they do anything at all, I should say. And so it's hard and it's distressing. It's probably one of the most distressing things that I encounter, and I think many of you probably encounter about people's weight loss and decreased appetite. All right. So now we're going to move on to the case discussion. And I'm not sure, I guess you guys.
Does somebody want to read the case for us? Be brave. Safe space. That word is Linux Gasto. I wouldn't have been able to know it either, and it would have scared me.
I'll be happy to read the case.
Thanks, Judy.
You're welcome. Austin is a 2-year-old boy with congenital cytomegalovirus, cortical visual impairment, Lennox-Gastaut syndrome, which is severe seizures, developmental delay, asthma, delayed gastric emptying, chronic constipation, dysphagia, and G-tube dependence. He is enrolled on hospice. He has been hospitalized 4 times in the last 2 months due to increased seizures and status epilepticus, requiring introduction of the new anti-epileptic drugs. Austin recently developed decreased feeding tolerance with vomiting following enteral feeds and increased constipation. He previously had a semi-soft bowel movement every other day and is now having hard stool every 4 to 5 days. Question: what can we do to improve his feeding tolerance?
Y'all could either unmute or throw it in the chat of some ideas from Dr. Daniels' lecture.
I think it'd be helpful if he pooed every day, or at least every other day, maybe.
And preferably not hard.
Maybe decrease.
Yeah, at
maybe
least soften it
decrease
up a
the
little.
flow rate.
Maybe decrease the amount of feeds or separate it into smaller amounts more frequently during the day. Putting water, maybe adding some water into them instead of just straight feeds.
Yeah, and I guess too, I would ask, it doesn't really specify in here what they're giving for constipation, because it sounds like he has a history of constipation, because it says increased constipation, or maybe he doesn't. But either way, what are they doing right now, just as far as what meds are they giving for nausea, vomiting, and the constipation? So again, reviewing his medication list.
Yeah, if he's not on Miralax, maybe put him on some Miralax. And how much water is he getting with the feeds? Something so he got regulated. You could also do, if it's not contraindicated for overload, you could do like a crisis to give him some extra fluid while he's getting used to the Miralax.
Yeah, and Dr. Daniels, it does sound like there was a change recently with all these hospitalizations, and that they added this new anti-epileptic drug. But it sounds like he already has really severe seizures at baseline. So I wonder how that anti-epileptic is affecting his quality of life. And also, I'm curious to know what the goals of care are, which might also allow us to know potentially there was a link with this new anti-epileptic drug that's causing him to not tolerate his feeds and causing more constipation. And depending on the goals of care, we might redirect his care plan in some way.
Agreed. And maybe we can, I think the next slide talks about just what he's currently on. And everyone can take a look at, this does not include his anti-epileptic medications, which we know got changed and a new one added. So everyone who wants to take a look at what he's currently on and what you would, in addition to the things you have already recommended, kind of what would you adjust on this, or maybe not adjust or add to or take away?
Well, the Zofran might be adding to it, just from the side effects. If he's taking it twice a day, I'm not sure how bad his nausea is, but is he nauseated because he's constipated, or is he nauseated from another reason?
Yeah, I think that's great. You know, thinking about, like we talked about, side effects from other medications. So Zofran classically causes constipation, and could we decrease that? Could we add a different medication in place of that?
You may also consider increasing that Miralax. He's just on that once daily right now, and maybe he could use a little bit more of the Miralax.
Yeah, I feel like that's something that parents aren't always aware of, that we can titrate Miralax up and down based on what the bowel movements are doing and how much constipation the child's experiencing.
Can y'all hear me?
It's kind of breaking in and out, Christy.
Maybe
Okay, yeah, it keeps kicking me off, and I'm gonna have to hop off for team, but maybe think about some probiotics also. And I miss you, Kenzie.
Good seeing you, Christy.
All right, I have to hop off to get on the team.
Tell everyone hi for me.
All right, I will. Bye.
Yeah, I think to Dr. Autry's point about the titration, I do a lot of clinic here, and I think it's relevant too for home visits for hospice, because when I'm on call for hospice, I do this a lot too, is really trying to hand people a piece of paper about, we talked about the mush and push, but how do you actually titrate those medicines? What is the max dosing that you could give someone? When should they do that? And I think someone said on here, aiming for a bowel movement every day, a soft bowel movement every day to every other day. And if it starts hardening, which one should we lean on more? If we're getting, not having that consistency, kind of what to do. So having something so parents can, or families can feel empowered to titrate these medicines, because it's not often in medicine that we allow people to titrate their medicines. And so I think that's a part that surprises people, that, oh, I can do this and it's safe to do this. But I think we had some good ideas thrown out there about adjusting both the osmotic and the stimulant laxative, potentially changing out the Zofran, potentially, we can use glycerin suppositories, or maybe we need an enema if the stool is actually hard, to try to loosen it up. So we can go to the next slide and see kind of what some new medication regimen would look like for this patient. So just talking through it, it looks like, definitely like y'all said, increasing the Miralax to at least a cap daily. Again, he's having hard stools, so we want to loosen those up with the mush, right? He's also going more or less frequently, so you can increase the Senna to BID, so he has more of the stimulation, more of that push. Adding on enemas, and maximizing his metoclopramide, which helps with delayed gastric emptying and nausea as well. And someone also said, thinking about changing out the Zofran. So instead of having Zofran maybe as first line as needed. And they were taking it on the schedule, right? They were taking a BID, making it as needed, and trying, adding on haloperidol or Ativan, and making potentially that first line over the Zofran to lessen the constipation. Any other thoughts on that?
Yeah, I think I missed that on the other side, on the other slide, that he was taking the Zofran twice a day. So it was like scheduled,
Mm-hmm.
even though it wasn't ordered that way. So that's always a good reminder to make sure that, like, even though the prescription may say one thing, that doesn't mean that they're taking it like that, and to assess that.
Yeah. All right, we'll move on to the next section. Does someone want to read the rest of the case discussion?
I'll be happy to jump in. Austin has some initial improvement in constipation with semi-soft bowel movement every other day. He continues to have frequent vomiting, abdominal distension, and pain associated with enteral feed administration, despite titration of medications. He currently receives bolus feeds, 350 mLs at 6, 9, 12, 15, and 18 via pump. What can we do now to improve feed intolerance?
I would maybe think about looking at whatever he's being fed. Is he having some sensitivity, like is it lactose or something like that? And maybe adding lactose, and like I think Cindy or someone said before, maybe adding a probiotic, and he's having distension also. From my perspective, I would teach the family a little bit of massage, maybe add like Mylicon or something to help with the gas bubbles, maybe some warm packs to help with just some of the symptoms. But I wonder, is there some other underlying issue causing that still? I would just be looking kind of at treating some of the symptoms until the underlying cause was determined.
I also think it's always reasonable for these kiddos who have severe neurological impairment to just really reevaluate this idea of feeds versus medically provided nutrition, hydration, how we sort of culturally and spiritually connect to this idea of feeding children. And many times when we're calculating feeds or medically provided nutrition, hydration, we're taking into consideration, their age, their BMI, this, that, or the other. And it doesn't necessarily mean that metabolically they actually need all of those feeds or medically provided nutrition, hydration. And so a lot of times we see these kiddos and they're very, for their size, very well nourished is how I like to say it. And it doesn't necessarily mean that all of those feeds they're getting are actually helpful and beneficial. And so Dr. Julie Hauer, who is like a expert in the area of children who live with severe neurological impairment, will say, okay, so at this point we've improved the constipation. So now let's have like a feeding intolerance care plan. And she would have like 5 or 6 steps that the family, in collaboration with the family, of like, what are we going to do when these things happen? And for every kiddo that might look different. And ultimately it might mean that we're starting to decrease the medically provided nutrition, hydration, by 20%, 25%, 50%, while we're still doing all the other things to ensure that a child is as comfortable as they can be. And again, it's contingent upon goals of care. But overfeeding is a thing, especially for these kiddos who are on a ton of other medications that might be constipating and or, affecting their GI tract, because when you have alterations of the CNS, the nerves in your, abdomen don't connect the way our nerves do with our brains with typically developing kiddos. So stopping the feeds for a little while, giving a break, venting the bag, potentially starting a little bit of Pedialyte for maybe a couple of hours, and then like reestablishing, okay, let's try to titrate back up to where we were. You know what? We tried to titrate back up to where we were, and this just isn't helping. We've made the constipation better. We've done this, we've done that. Maybe now it's just time to decrease feeds, see how that goes for a while. And so you have to be kind of nimble and creative, and have metrics of success as well. And ultimately, at this point, depending on the goals of care, it might mean that we're starting to protect a child from medically provided nutrition, hydration slowly if we're seeing improvements in their quality of life. Knowing that time may be short no matter what we do, but a child's not going to die from decreasing medically provided nutrition, hydration. They're going to die ultimately from their severe underlying condition. That's their primary diagnosis, and that's sometimes tough to navigate for families and providers and clinicians.
And also just to add from the chat, someone had suggested trying continuous feeds as well. So I think like Dr. Mo said, you know, whether it's pausing them completely and then slowly reintroducing Pedialyte or switching to continuous before you rev back up to the bolus, I think just rethinking the feeding schedule and seeing how, and volume and schedule, and seeing what changes could be made that could show improvement.
And we didn't talk about what Austin is on for his CNS, but another thing that comes to mind at this point too is visceral hyperalgesia, and potentially considering the addition of gabapentin or Neurontin once you get to a point to where you've tried some more conservative measures. We call it vitamin G for our kiddos, and it rarely makes anything worse.
So if we look at the next slide, so this slide says kind of what we already talked about, what everyone kind of commented on is just changes, thinking kind of out of the box about how do we, even if this has been done so often that they've been on these feeds for X amount of, months, years, how can we change it? How can we change the rate? How can we change the amount or reintroduce? So there's some changes suggested there. And I'll just go on to the next question, or to the next bullet point, which is due to increased suffering. And this is what, Dr. Mo was getting at, is teasing out the goals of care, right? So due to increased suffering and reduction in quality of life, Austin's parents are in discussion about redirection of care to focus solely on comfort without continuation of enteral nutrition. So kind of some questions to pose to y'all are, so how do you introduce discontinuation of tube feeds or enteral nutrition or medically provided nutrition and hydration? And how does it make you feel?
Good afternoon. I think one of the things is that anticipatory guidance, and Kinsey, both you and Lexi brought that up, so that the family knows where they are and what they can kind of anticipate. They know the guidelines that they can work between, and I think that probably helps them in their preparation as they begin to regule.
And I think in the chat, Cindy had mentioned I think starting to introduce it by pointing out the concern that the feeds are causing more harm than good, and kind of explaining why we think that. And often cases, the family are already noticing, them complaining of the feeding intolerance, and just pointing out that his body's not able to process it like he was before because of his brain.
And I think Judy brings up a really good point of that anticipatory guidance of just talking about, these are all the things we're going to do over this amount of time with the hopes that we achieve X, Y, or Z. And also we may get to a point where despite our best efforts, what we're doing is no longer helping in the way that it used to. And this is what this might look like. This is what families may consider. And it may be, depending on the goals of care, admission to the hospital to start TPN and that sort of thing, and thinking about central lines and all this poking and prodding versus, re-going versus let's try this and see how it goes for a time-limited trial. But this is not like a one-day conversation and then poof, we're discontinuing medically provided nutrition, hydration. To me, especially for a child like Austin, this is something that occurs over the course of weeks to months to even sometimes years. And it just depends. And as far as like that question, how does it make you feel? I will just admit the first time I started understanding that this was a thing, as far as discontinuation of medically provided nutrition, hydration, it made me feel uncomfortable. As a Southern person, especially, like it made me think, oh my gosh, are we going to starve this patient? Like, how are we just going to stop these things? And it was really helpful for me to read the AAP guidelines and then to be able to sit with someone who had, has had more experience than me to explain what this meant. It's not like Austin is eating, etouffee or gumbo and enjoying it and having pleasure from eating by mouth. Austin has been supported through a G tube with medically provided nutrition and hydration. And that is very different. And it's not like Austin is asking for food or telling you he is hungry or that sort of thing. And we're saying, no, you can't have any of these feeds, and that's where we have to be very, very careful about language as well. And so I think it's very common for both the care team and families to potentially feel very uncomfortable about this concept of protecting children who's experiencing end of life, who's experiencing a serious illness, about protecting them from medically provided nutrition, hydration. And that's where just sitting, being curious, being gentle, and being able to explain the difference between protecting a child from medically provided nutrition, hydration, and starvation are two extremely different things. And talking about that over time with a family is really helpful, and especially supporting your team as the pediatric hospice nurse on the team as well.
I think y'all make really good points. And I think sometimes in the hospital, we do, the team will do consult for the dietitian to come, and the dietitian tends to look at what Lexi was saying, Dr. Morvan was saying, that you have this standard size child and this is their age and this is what they need. These are the calories that they need. So we're trying to push those calories into them, maybe not taking into consideration that they don't need that many calories. Those are tough conversations, but interesting concept. And I would call Dr. Morvan and say, Dr. Morvan, maybe you could go talk to that dietitian. Because that's a hard conversation to have.
Mm-hmm. And I think too, when Dr. Mo and everyone's talking about this and how this is a process, right? These conversations, and it takes time, and as we do these trials, I mean, and families notice, and we're replacing the medically provided nutrition and hydration with other things that maybe provide comfort. Maybe that's in their environment, maybe that's music, maybe that's other things that the family knows provides comfort. And also recognizing that and doing that kind of expectation management, that as we kind of get closer to dying from our primary diagnosis, right? Not from decreasing or stopping medically provided nutrition, but as we approach the end of our life, that those signs that y'all are looking for always of that abdominal distension, those are clear signs that things are slowing down. And I think people, when Lexi talks about starvation versus like discontinuing medically provided nutrition, very different things. And a lot of people ask all of the time, is this person, are they starving? Are they feeling the sensation of that? And, you know, there's the thought and the literature to support that the people are not, you know, necessarily starving or suffering from stopping that, and rather they get into a state of ketosis, and it's almost like a mild euphoria that you experience. And I think reading through the article, the brief article that they put, that we put in the chat, for the Courageous Parents Network, that actually the one that Lexi was just talking about, Julie who was it, Lexi, that you said?
Julie Hauer.
Julie Hauer. She wrote that article. So, and she talks about it, and it's very powerful, and it really talks about kind of the pathophysiology of why things become non-beneficial.
Does anyone have any experience taking care of children at home when the families are deciding to protect against medically provided nutrition or hydration? And I did go ahead and provide a link that there was a study recently, I think it was just published in March, where the researchers provided observations of children. And so they talk about their comfort and the symptoms that they experience before and after. So I think that that's really helpful too. Especially if you hadn't experienced this before, but it comes up in the future when you're caring for pediatric patients on hospice.
All right, we'll go to the next slide. So I want to read the end of the case discussion.
I'll read it, Dr. Daniels. Austin's parents made the loving decision to discontinue artificial nutrition and hydration at home. He continued to receive loving care with the administration of medication to control symptoms and had improvement in his abdominal distension, nausea, vomiting, and overall discomfort. He was more alert and smiled while listening to music. Austin died peacefully 7 days later with his parents, 2 brothers, Golden Doodle, private duty nursing, and a hospice nurse by his side.
And this was a patient cared for at Le Bonheur Children's Hospital. And the orange ribbon that's been on this case slides is a symbol that his parents used in his memory.
And typically that is the anticipatory guidance when I give to families that are going to make that loving decision to protect from medically provided nutrition and hydration, is that we typically think of 7 to 10 days, sometimes less. And it depends on how sick the kiddo is. But also I've had little neonates and babies that were only getting around the clock morphine that we discontinued medically provided nutrition and hydration, and they lived for 5 weeks. And so it's always important, you know, to let families know that we don't have all the guidance and literature in pediatrics to know exactly, but saying something to the effect of days to weeks. And then if they're very, very sick and they may not have their reserve, you know, they may be on the days, and then we'll know what time. But I usually say days to weeks, so that families aren't surprised one way or the other.
Great. I think the last couple slides are the resources, and certainly want to ask for any other thoughts or comments or experiences that people have had and questions that are related or unrelated to these topics.
I would say another thing that comes up frequently too, are families that are potentially, when they observe that their child experiences pleasure by feeding by mouth, even if we already have like swallow studies that show that they're at risk for aspiration, and their goals of care are to live as well as possible, but maybe they're not at the place where, you know, to where the child's still awake, and they really want to make sure that they're continuing to receive this pleasure, and the family knows the risk of, like, if they continue to feed by mouth, that an aspiration event could occur. And as long as they understand that that aspiration event is because of their underlying condition, and they want that, and they're still goaling to focus on comfort, like, those pleasure feeds are totally fine. Even if we're discontinuing medically provided nutrition and hydration, if they're like, oh, they never had, you know, Jello or king cake or whatever, and they just want them to taste it, like, that's something that you could talk about as well.
And just a reminder that we'll also send out the resources and upload them to the website. Maggie, do you want to wrap up with the announcements?
Yes, perfect. If you guys do have any, if you're wanting to view the recording after this session, or any of the previous sessions as well, those will be posted on our website. Do remember to complete the survey that we will be sending, or LMH PCO will be sending, if you do wish to gain CEU credit. And then I forgot to change this slide, but if you do have any questions, remember that, let me post my email in the chat, but that Reach email account is no longer, we're going to be discontinuing that. So I'll post my email in the chat, and just feel free to touch base with me if you have any questions or concerns. And then our next session is June 15th. So if you can join us next month, we'd love to have you. And please do, if you, we want to encourage you all to send in case submissions. We have a little link on the website to type in all the information. So you should find it easily on the website. Do feel encouraged to do that. We'd love to hear from you guys as well. Okay, dokie. And then
I'll introduce Stacy Melling. She's our incredible integrative therapies nurse at our at Children's Hospital New Orleans, and she's going to lead us in a mindfulness exercise to close our session.
Awesome. Hey, we just have a few minutes left, so I'm going to kind of go quick. This is grounding exercises, or just to give you all a little bit of, most people have done them. There's different versions of them. A lot of them do thing where you find 5 things, then 4 things, then 3 things, 2 things, and 1 thing. We've kind of adapted this for children to make it a little bit easier. And so I'm going to talk y'all through this. You know, kids don't always want to right away close their eyes. And I like this because sometimes at the bedside, when we need our own grounding, sometimes without, because if we start closing our eyes to get into that moment at the bedside, people are going to wonder what we're doing, right? So with your eyes open at the bedside, or, you know, right now you can kind of practice along with us, but when you're at the bedside, look, and you maybe start feeling a little bit nervous or anxious, look around and find 3 things in the room, and you can do it now, that are the same color. And when I'm working with kids or anyone, I just tell people to pick their favorite color. So my favorite color is purple. So it's real easy for me to find those 3 things and really focus on them. The next thing with your eyes open is to find 3 things that start with the same letter as your name. So that's kind of a grounding thing. And if you practice, these things are, they can be really useful, but they're also really good the more you practice them. And so now if you want to take a moment and close your eyes, and I'll have you kind of guide you in. So at this point, when we work with kids, we've built a little tiny bit of trust. So maybe now they can close their eyes. So if you want to close your eyes and just listen for the smallest sound in the room, just a little teeny tiny. Maybe it's your computer hum or air conditioning. Now, picture your ears opening up and reaching out and see if you can hear the largest sound in the room. For me, it was somebody opening and closing the door in the hallway. It's pretty loud. Just listen to what's that loudest thing. Maybe it's my voice. And then feeling. So we're going to tap into those senses, feeling the air on your skin, and just pay attention to the parts of your skin that are uncovered. Is that air warm or cool? Is it wet? Is it warm? Is something blowing on it? Just notice. And then feel the items around you. So for instance, if you're sitting in a chair, feel that chair under your thighs. Feel the floor under your feet. Feel the clothing that might be touching your skin. Is it soft? Is it scratchy? How does that feel? Just taking a moment to tap into that. When you're ready, just blink your eyes open. It's really as simple as that, just finding those few little things at the bedside. I've been using this a lot with patients, and I just want to share this with y'all because when we're at the bedside and patients are feeling nervous, the very last one where you feel the items around you, patients are focusing on whatever. Maybe they're focusing on their stomach hurts or whatever. Breathing is what I've seen recently. Asking them to just pay attention to the bed underneath them, just to notice, because they can feel that, and that instantly shifts their attention to that bed underneath them. Or if they're in a chair, to feel where their head might be touching the bed or their legs might be touching the bed, to feel the sheets or the gown where it's touching them, and really have them focus on relaxing themselves into the bed and allowing that bed or the chair to support them. Just so you have that little tip to do, and you could do the same thing when you're lying in bed, right? And you can't go to sleep because you have all these things that you have to do. Pay attention, or if you're in your office and you need just a little woosah moment, pay attention to where your feet are, where your hands are, and pay attention to those things that are around us. And I believe they included the graphic on there too, so feel free to use that. If you need a better version of that, I can send that out to people because it looks a little squishy. That might be my computer screen, but any questions about that? I know that's not quite as deep as we've gone, but we only have a couple minutes left, and I just wanted to give you something so that when you're at the bedside in those quick moments, like, hold on, I just need to ground myself back into this moment. Any questions?
And Stacy, maybe you can send us the PDF and we can include it with the resources.
Okay, I'll do that. Sure.
Thank you so much, Dr. Daniels, for joining us today. It was a wonderful lecture. And thanks to all of the participants. Y'all are awesome. I see a bright future for serious illness in pediatrics in Louisiana. Stacy, you have something to say?
I do have one question, and this is maybe an offline thing for Dr. Daniels. She did mention biofeedback for constipation. I don't think we have enough time to go into that, but if there's stuff that you know about it, maybe we could chat offline about that.
Sure, yeah. Definitely, Ashley, if you want to connect on emails together, we can certainly go into that. I do have to run to clinic though, but I appreciate everyone for letting me come in and give a lecture or talk with y'all, not even lecture.
I appreciate you.
Yeah, thanks y'all. Miss you down there in New Orleans.
Well, I think that wraps us up. Thanks again, everyone, for joining, and look forward to seeing y'all next month.
Bye, thanks.